Hi, everyone. I'm Dr. Michael Miyazaki, and thank you for joining me for part two of our discussion on endodontic irrigation. Now, I think that's a really important topic to understand. So, this is how my week started off. First day back, first patient of the week. She came in, and this is a patient that I really enjoy seeing. And you can see that this is 230, the lower right first molar. And there's been this large amalgam restoration there. And over the years, we see the little cracks radiating out. We see all um, the discoloration where the amalgam and the tooth come together. And we had been talking about the need to replace this restoration, perhaps with the filling, but perhaps with an indirect type of restoration. Well, she had been putting it off because it hadn't bothered her. And this restoration had been there for decades. Well, she came in again the first day of the first patient, first day of our work week, and her chief complaint is that she's got this toothache that began just a few days ago. And it's feeling like there's a little soreness not only in the tooth but also in the gum area. So yeah, we take a PA, and right away we see in the PA that there's a darkening around the apical area, the mesial restoration. Sorry, the mesial root of that tooth. And if we go up to the top of the tooth, we see there is an amalgam restoration. We saw that in the photo, but along the entire buccal cervical margin area that we placed a composite because there had been some decay and some abfraction down there. So we were trying to cover that area up also. If you look at the bicuspid in front of that molar, it looks like there could be some decay, but you'll see in the photo that that's just a really deep abfraction area. So that tooth was okay. So first thing we had to do is we had to start with a diagnosis. Which tooth was bothering her and why was it bothering her? So we went to do our percussion test. So we went to the first and second bicuspid in front of that molar, tap, 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 tap. The patient felt the tapping, but it wasn't causing her any great discomfort. When I went to tap on number 30, that lower right first molar, that kind of opened her eyes. So that was a lot more tender than the previous teeth that we had percussed. Then we went to the cold test. So I take my little Q-tip and I spray it with my endo ice, and I put it on tooth number 28, and she raised her hand. She could feel it. I removed the cold. She put her hand down. Just kind of a normal transient reaction. Went to tooth number 29. The second bicuspid did the same thing. She felt it, but it wasn't extreme. And then when I removed the cold, the sensation just kind of subsided. Went to number 30. Didn't feel anything on the buccal. Went to the occlusal. Sprayed a little bit more. Went to lingual just to see if we could elicit any response, and there was no response. Went around the tooth just to kind of check to make sure there wasn't a chance of cracks. You could also do a tooth sleuth, have the patient bite down on the different cusps. But from what I had seen already, tapping that tooth was very tender. With the cold, there was no response. I had a pretty good idea in the darkening of the apical area, that mesial root, that we were dealing with a necrotic pulp. So what do you do at that point? Do you refer the patient out to your endodontist, or do you go ahead and perform the root canal yourself? So, I looked at the schedule. We had the time to do it, and we got in there to do a single visit root canal, core buildup, and crown restoration. So what I do is I go in there, I prep the tooth, leaving the amalgam if it needs to stay there. I prep the tooth as if it was just a traditional crown prep. I scan it with our CEREC, and we begin to design and mill out the crown for tooth number 30, or the lower first right molar. And then we do the root canal. And so by the time we're done with the root canal, our crown's already fabricated, and we can place the core and the crown all at one time. Now, when you do this, you want to be fairly efficient, right? Because you need to get that root canal done in the time it takes to design and mill, then glaze your crown, the restoration. But I think the biggest thing about this when we do this is you have to be pretty confident that your root canal is going to work, because you don't want to do the root canal, put the crown on, and then have the patient come back saying, there's swelling there or still more pain there, because maybe you have to go back in there, retreat it, or it just doesn't instill a lot of confidence in the patient about what's happened. So on the far right hand side, you see we've got the root canal finished up. We've got our percher points right down to the apex of the tooth. There's a little bit of sealer that was extruded out the apex of that mesial root, and that's where that abscess, the infection was down there. Not going to worry about that. The body's going to resorb that. We're going to be fine. But all week, the patient's been fine and hasn't complained of any discomfort. So let me move my head over to the other side of the screen. So it was all done in one visit, which was very convenient for our patient. So what we're going to talk about is how do we know when we do a root canal procedure that the patient most likely is not going to have any post-op discomfort. We know that down the canals we have to get all that tissue out, we have to get the bacteria out, any of the infection, exudate that might be down there, we need to prayerfully drain all that out. We know that from that main canal that we're placing our files into, that we have all these lateral canals and tubules that open up into that main canal. What we have to do is we have to not only debride the main canal, but we have to disinfect all those other microscopic spaces. And that's, I think, hard to do because research done, and we mentioned it during our last webinar, that Dr. Peters showed that a lot of the canal spaces are not instrumented, because we've got a large canal space, let's say, and our files are going down one side of that canal, missing the other side, or we have all these lateral anastomoses that we're not able to get the files down into, and as I mentioned last time. So his research showed that about 35% of the canals go untouched, and that's areas where the bacteria or even tissue may remain. So in the examples they showed, the red areas are the areas that have not been touched by a file, whereas the blue areas have been touched by the file. So a significant amount of the canal could have a smear layer, or it could have bacteria, or it could have tissue on it, and that bacteria is going to cause our patients pain possibly after our procedure is done. So how do we get around this? Well, at this point, it's really the irrigation that does the rest of the job. Our irrigants have to get into the spaces where our files do not touch the tooth and the canal walls and all those lateral canals and anastomoses, and it has to get into those areas to dissolve the tissue and disinfect the canal system. So what I was leading up to last time is that a lot of us, when I was in dental school, we learned to use sodium hypochlorite, and the sodium hypochlorite was basically Clorox, and so we were taught. And I went to many lectures after I graduated, and they still said, go out and buy your Clorox, and then maybe use it 100% or dilute it 50-50. And we mentioned it that we don't really know what the concentration of our sodium hypochlorite is in that Clorox bottle, because that Clorox bottle could be fresh, it could be great, or it could have been sitting on that shelf for 6 months or 12 months. When it was transported, it may have been exposed to sunlight. It could have been a warm truck that it was transported in, and so that 8 or 6% sodium hypochlorite concentration could be down now to 2 or 3. And if we dilute that 2 by 50%, we could be down to 1%. And it could be even worse. We don't know, because it's not really a controlled pharmaceutical type of liquid that we're treating our patients with. Well, we talked about this last time, is that I showed the video of how quickly root canals can be done these days, because we've got the mechanical, rotary, or reciprocal systems, depending on which you favor, that helps us get these canals shaped and enlarged for our obturation much faster than when I learned how to do root canals almost 40 years ago. Well, because it's so much faster, our irrigant exposure time down in that canal has been shortened dramatically. So if before I was using my little hand files and it took me an hour or 2 hours to finish my root canal, well, you know, my fingers were sore at the end of that, but our irrigant had a long time to sit down there and dissolve out the tissue and get into the lateral canals possibly. Well, as the filing systems got faster, the incidence of retreatments went up, because we were filing everything out. We were dirtying the canals, but we weren't giving our irrigants at the time enough time to work, and so we weren't getting the canals as clean, or we weren't getting them disinfected like we would have liked to. So as I have mentioned, because our endodontic systems have become so fast, we now need to use irrigants that help us disinfect the canals quicker. And so here are these three bottles. One's the Chlor Extra, which is 6% sodium hypochlorite with proprietary surface modifiers and wetting agents. Then in the middle we have Smear Off 2-in-1, which is actually an EDTA-based formula enhanced with chlorhexidine for added bactericidal effects. And then CH Plus, which is 2% chlorhexidine gluconate, has surface modifiers and wetting agents that again help it to be more effective. So that's what we're going to do, is we're going to look at these bottles and the effects that they have to make our root canals better. So what do they all do? Well, you saw they all have surface modifiers and added wetting agents, and that's to lower the surface tension. When we lower the surface tension, these liquids can get into all the lateral canals much easier, wet the canal walls much easier. So they're going to be more efficacious and much more efficient. I spoke about it in kind of part one of the endodontic irrigation program, is that we've got a Vista Apex pharmacy grade sodium hypochlorite, and we have EDTA with an optimized pH. But these three bottles, the Chlor Extra, the Smear Off 2-in-1, and the chlorhexidine CHX Plus, are the ones that have these special surface modifiers. So let's go look at Chlor Extra. Chlor Extra is an enhanced 6% sodium hypochlorite solution designed for the irrigation, debridement, and cleansing of the root canals during and after instrumentation. Again, the addition of these wetting agents that are proprietary surface modifiers allows this solution to wet the canal walls much easier, faster, and penetrate into those little tubules. Because of that decreased surface tension, you have improved contact with the solution against the tissue and against the wall, and better lubrication. Lubricity. I wanted to say that word. So it has better lubricity. And if we clean out that tissue, especially with our sodium hypochlorite, which is going to dissolve the tissue and disinfect the canal, we can reduce our post-treatment complications. So if I put that crown on, I don't want that patient calling me later that day saying, hey, that tooth's still really sore. Can I come in and have it looked at? No, you can't come in and have it looked at because I've already capped the thing off with the crown. So we really need to feel good about our root canals when we're doing this type of work. So let's look at this Chlor Extra. This is done by the ADA, a professional product review. And what you're looking at is a surface tension. So remember, if we can decrease the surface tension, we get better wettability of the canal walls and all those little lateral orifices, the tubules. So the lower the score, the better. So if I'm low, that's a good thing because it shows that we have a decreased surface tension. And here is a dye in a liquid, and it's contained as a small dot. But when I apply a wetting agent in the middle of it and I break the surface tension, it can spread out. So just imagine that these liquids with their surface modifiers can do the same thing, kind of explode into those lateral spaces. So the Chlor Extra actually has half the surface tension of your standard sodium hypochlorite, and that gives it greater oxidizing power. So it can digest that tissue twice as fast. So it's faster and more effective. And remember, it's not like we have this canal that's filled with a bunch of meat or tissue inside of it, and this has to dissolve it all. Our files are dissolving most of that, or removing most of that tissue. It's the Chlor Extra that then goes in there and dissolves out the remnants. So you want it to be very effective and work very quickly. This just shows the tissue dissolution. So the higher the bar, the better. It's showing that in any set amount of time, 5 minutes, 15 or 30, that our solution's dissolving more. So if you look at the bars for the Chlor Extra, it is the highest. The next bar down, kind of that lavender color bar, is your sodium hypochlorite. So the sodium hypochlorite that a lot of us are using works more slowly. And so why not use an irrigant that's going to work faster, because we're doing our root canals faster. And so this is kind of a time-lapse video, just showing on the left-hand side we have basic sodium hypochlorite. On the right-hand side we have the Chlor Extra 6%, and we have tissue in this vial to kind of mimic what pulpal tissue is like. And on the right hand side, you can see the Chlor Extra vial. That tissue is dissolving very rapidly. So right about the 30-minute mark right here, there's really no tissue. Whereas on the left hand side, where we have our standard sodium hypochlorite, there's still probably about half of that tissue left. And as our clock on the lower right hand side ticks off at over an hour, there's still some tissue there. So it's just showing that the Chlor Extra is much faster, at least twice as fast as the sodium hypochlorite. So it's just going, and we're going to go over an hour, and there's still tissue in that sodium hypochlorite vial on the left-hand side. So you can see right now we're at over twice as long since the Chlor Extra tissue is completely dissolved, and it stopped at 1 hour 11 minutes, and it's still containing tissue on the left-hand side. And then we talked about this. As I take the file and I go up and down the walls of the tooth, we create dental mud. It's all the debris, the tissue, bacteria, all the tooth particles that's all kind of muddied up inside there. And we have all these dental tubules, and those smear layers plug up our dental tubules. So we need to figure out how to remove that, how to open those tubules up. So we have the EDTA 17% with an optimized pH to open up the tubules. Basically, it's going to chelate all the particles with the ethylene diamine tetraacetic acid, EDTA. And research shows that more than concentration, it's the pH that makes it more effective as a chelating agent. So the Vista Apex EDTA has a pH of about 8.5. It is optimized for the chelation. And so what EDTA does, it removes that smear layer. And go back to our composite bonding. When we're doing composite bonding, we put the etchant on the tooth structure to remove the smear layer, which is all the debris that's created as we prep a tooth or prepare a prep in a tooth. And so we have to remove that smear layer so that our adhesives can penetrate into the tubules and give us a strong bond. Well, the same thing happens when we use EDTA and a bioceramic sealer. Is the sealer is able to penetrate when we've opened up the tubules into those tubules and close those areas up and create a much stronger bond. So after we create that dental mud, if we use the EDTA to chelate out all that dental mud, and then sodium hypochlorite one more time, because now we've opened up the tubules, and if we put the sodium hypochlorite down into the canal, that sodium hypochlorite can then get into those dental tubules to disinfect that area. And we'll talk about in the future, but if we activate that, which means we agitate the fluid within the canal and we kind of force it out into those lateral canals, it's like cleaning the tooth very, very thoroughly. And we'll cover that more in an upcoming webinar. So copious sodium hypochlorite should be used to wash out the remnants of the EDTA once we've done the cleaning and the shaping. And we can use ultrasonic activation just for better penetration into those dental tubules. And so that's what we'll be talking about in future webinars. So now we've got the tissue dissolved. We've removed the smear layer with the EDTA. Then we go back in with the sodium hypochlorite. We make sure we get into those lateral canals and make sure that everything's disinfected very well with the sodium hypochlorite. Now, some doctors will use chlorhexidine, so 2% chlorhexidine, just to irrigate and cleanse that root canal system even further. One thing to remember, though, is if you're using the sodium hypochlorite and chlorhexidine, you don't want to go from sodium hypochlorite straight to the chlorhexidine. In between those, you either want to have water to flush out the sodium hypochlorite, or maybe alcohol. I typically use water, or the EDTA. If you go straight between the sodium hypochlorite and the chlorhexidine, it's going to produce this red precipitate parachloroaniline, PCA. And so if you want to avoid that, because one, it will discolor your tooth. Two, it can be kind of a toxic residue down there. Some have said it's even carcinogenic. So you really don't want to combine your sodium hypochlorite with your chlorhexidine. Then we have the enhanced chlorhexidine, which is our CHX plus, which is basically a 2% chlorhexidine gluconate with more powerful wetting agents and that proprietary surface modifier. So again, we lower the surface tension, and you all know what that does. That allows better wetting and better abilities to get into the smaller spaces. So many times this is our final irrigation step for that long-lasting cleanse that we want inside the canal. And it too, because it's getting rid of all the bacteria down there, promotes adhesion of your sealers and your obturation material inside the tooth. And this is just a study that was done. So now the red color is where the bacteria has been killed. The green is where the bacteria is still living. So you basically take basically like a petri dish of bacteria. You put CHX plus with its surface modifiers on the tray on the left-hand side and regular chlorhexidine on the right-hand side. And you can see that the right-hand side has much more green. So it is not as effective at killing the bacteria. So on this one, we're looking at the levels of bacteria left behind. We've got the CHX plus, which is the light blue, and the regular chlorhexidine at 2% also. That's more the purple line. And you can see at the 0, the far left of this bar graph, they're at 100% bacteria count. And within 10 seconds, the CHX plus drops that down below that dotted line, which is our detection limit in the study. Over time, the CHX 2% regular chlorhexidine is bringing that bacterial count down, but it's taking 3 minutes in this study showing for it to get below the detection limit versus the CHX plus doing it in 10 seconds. So again, it's much more efficacious using the CHX plus. The tongue twisters. And this is just another study showing that in a biofilm, the longer a biofilm exists, the more complex that colony is going to become. But with CHX plus, at the 3-minute and 10-minute exposures, you can see that most of that biofilm has been affected, whereas the purple line above that with the X and the green line with the triangles is your more conventional chlorhexidine, and they do not do a very good job. The levels, even after 12 minutes, are still 50 to 70% of that bacteria is still alive. So it just shows how much more effective the CHX plus is with its surface modifiers. So in this case, a lower number is a good thing. Now, if you want to make it even easier, you don't have to worry about having your EDTA and your chlorhexidine actions. Vista Apex, we have Smear Off 2-in-1. Basically, Smear Off 2-in-1 is your EDTA and your chlorhexidine mixed together. So it removes that organic debris and facilitates the flushing of the canal debris. But the nice thing is you can go from your sodium hypochlorite to your Smear Off 2-in-1. So basically going from your sodium hypochlorite to your CHX equivalent without having to worry about that precipitate being formed. So you don't have to do the rinse in between there with your water, alcohol, or EDTA. So we can get in there, have even better chelation, clearing out 27% more of the dental tubules compared to 17% EDTA by itself. Why is that? Because it lowers the surface tension, and because of that, it better penetrates all the tubules and wets the walls of your canal. And it's shown even to have better suspension of calcium. So again, calcium is going to be a lot of the tooth structure that's in that dental mud, and we want to just kind of put that in suspension. So after using Smear Off, you can see how all those tubules are nicely opened up. There's a competitive product on the right-hand side, and it's still not as clear, but on the left-hand side, we have really nice open tubules. And this is just proof to showing that if you went from sodium hypochlorite to chlorhexidine, on the left-hand slide, you would see that red precipitate being formed. But on the right-hand side, if you went from sodium hypochlorite straight to Smear Off, your EDTA chlorhexidine equivalent, you would not get that kind of precipitate being formed. So it makes your protocols much, much easier. So again, what Smear Off does is it removes that debris in there, both the organic and the inorganic debris. It's much more effective at doing that than just straight EDTA. And so you've got the combination action of your EDTA and your chlorhexidine. So percentage of open tubules is shown here. We've got on the left-hand side the smear off in the purple bars being very high, and the saline doesn't do anything. It doesn't open up any tubules, so you don't see a saline bar here. But compared to some competitive EDTAs, the light blue line, the third line over, you can see that that hasn't really opened any of the tubules yet. But the smear off has done a great job, both in the coronal, middle, and apical sections, opening it up. So a higher score is what we're looking for here. And then just to make it simple, because I know especially a lot of general practitioners aren't doing root canals every day, Vista Apex has this kit, and I really like this kit. This kit's called Canal Clean, and it's basically a packet. You order a box, and there's a bunch of these little packets in that box, and when you're ready to do your root canal, you open up that packet. It's got 12 cc's of the Chlor Extra, which is the enhanced sodium hypochlorite. It's got 6 cc's of smear off, which is the enhanced EDTA chlorhexidine equivalent. It's got Aplavac side vented irrigating tip, so you can go down to canals and irrigate with these solutions without worrying that you're going to express it out the apical portion of the tooth. And it even has a micro aspirator, so when you're done doing all your irrigation, you take the micro aspirator, you go down into canals, and you have it attached to your suction. It dries it out. When you go in there with your paper points, they're going to all be fairly dry. And with most of these bioceramic sealers, you want to have just a little bit of moisture inside that canal, because that will activate the set of the sealer. So we've got different protocols. If you're doing a conventional protocol, you'd be using sodium hypochlorite typically to dissolve the tissue and disinfect the canal. Then EDTA to remove the smear layer. Rinse that out, because we don't want to have any sodium hypochlorite left behind if we're going to put chlorhexidine in there. But if we can go sodium hypochlorite to dissolve the tissue, disinfect, EDTA to remove the smear layer, and then one more time with the sodium hypochlorite, because now we have the smear layer removed, all those tubules are opened up, and our sodium hypochlorite can get into those lateral spaces better. And or we could use chlorhexidine plus, CHX plus. But now with our enhanced protocol, we can just use Chlor Extra, because Chlor Extra has our special surface modifiers, and so it's going to be much more effective, much faster. And then the smear off, which is the 2-in-1, that is our EDTA and our chlorhexidine all in the same. So we can go straight from our Chlor Extra, then go straight to smear off. We don't have to irrigate in between, because our Chlor Extra and our smear off aren't going to create the precipitate in there. And we've got a clean canal, dry it up, and then obturate. So in future webinars, we'll talk about, well, how do we activate this, and then how do we seal this? And I will tell you part of what that case success was all about that I showed you, that I started off with during this webinar, is that the alkalinity of that bioceramic sealer helps to prevent post-operative discomfort, helps that tissue in the apical area of that tooth where that infection's been to help it heal up, and then help the prevention of future bacterial proliferation in that area. So we'll talk more about that. There's just so much to share with you, and I hope you're getting something out of this, or these presentations. I thank you very much for joining, trying to give you a little bit of the information a little bit at a time so you don't get over inundated. I hope you can watch these programs over. If you have any comments, if you have any suggestions, I'd love to hear from you. And if you'd like to make sure you don't miss anything, just hit subscribe. If you think this is kind of cool information and you have some friends that you think could benefit from the information, please pass it on. We just want to grow our community. This is our community where we can share ideas of how to do better dentistry and help raise all ships. So thank you very much, and I'll see you next time. Take care.